Thanks, Paul. I'd like to thank Epilepsy Ireland for inviting me, and to Wendy and Peter in particular. So I feel like I'm Larry Gogan, after the top 10, I prefer the top 100 myself because, it lasts longer. So I'm going to start straight at the top, though. Like Larry Gogan, he starts at number 10 and goes downwards. I'm going to start at the first one. But it's not necessarily in order of importance. But I thought, obviously it can be very traumatic to be told that one has epilepsy, and no one minimises that. But I think the first thing I'm going to talk about is, it's a very common condition, so you are not alone. It's one of the most common neurological disorders. So maybe, Christine Linehan did studies in the epidemiology of epilepsy in Ireland, and there's 40,000 plus in the Republic of Ireland. So, and about 50 million worldwide. So you're not alone. It is one of the most common conditions. So you're not the first person to have it now. It's not belittling your experience. So that's the first thing I want to say. The second is, and we hear, we're all guilty, I think, and I suppose as a neurologist, we tend to see people with more problematic epilepsy more frequently. But we forget that most people with epilepsy live full lives, and that's the objective. It's treatable. The aim is for a full life, and I suppose we should emphasise what you can do rather than what you can't do. So quality of life is important, and I suppose the ideal situation is if you're living your full life and someone finds out that you have epilepsy. I didn't know you had epilepsy, and I don't really think I have it either because everything is under control. So that's the ideal, and that's fulfilled in lots of people, and most people with epilepsy, that is the case. And then I suppose the second thing is I'm kind of going to what is epilepsy and what isn't epilepsy. I suppose epilepsy is 2 or more unprovoked seizures. Everybody's epilepsy is different. There's, I suppose, Norman Delante keeps talking about the epilepsies rather than epilepsy. So, there's a whole spectrum of disorders, different causes. So there's the whole spectrum. And we should talk about the epilepsies, really, rather than epilepsy. But I suppose it won't be Epilepsies Ireland, it'll be Epilepsy Ireland. I'm sure they won't change for that reason. And then what epilepsy is not. I suppose there's a lot referred earlier to saying it's not the mother's fault or the parents' fault that the child has epilepsy. It's not a moral weakness condition, and that has actually been down through the centuries. There has been this idea that epilepsy was the sacred disease. It signified possession by demonic forces, and it took quite a while actually to realise that it's a neurological condition. And the biological basis of epilepsy has really been only understood for about 100 years, which of course in human history is like a nanosecond. So epilepsy was often seen as a supernatural happening as a consequence of curses and possessions, witchcraft, possession, and even contagious, And I worked in sub-Saharan Africa for a while, and that was actually not so much demonic possession, but you don't touch, stay back from the person who is having a seizure, because you may get contaminated, you may develop it. So, we don't want to dismiss. I think in a Western audience we don't expect that, but I've certainly seen it in this day and age in different parts of the world. And again, it's interesting to read this from Mark's Gospel about my son who is possessed by a spirit that has robbed him of speech. Whenever it seizes him, it throws him to the ground. He foams at the mouth, gnashes his teeth, and becomes rigid. And the disciples couldn't drive the spirit out. So actually, as a description, whatever about the understanding of epilepsy when that was written, the description of it is quite, can be quite accurate of what seizure might look like. So today, epilepsy is clearly recognised as neurological illness, and there's been a huge explosion of knowledge about epilepsy. And the biology of it. Even though if in some parts of the world it is still regarded as a supernatural issue. So the next issue I think is to clarify. So we want to know what epilepsy is and what it isn't, and the next thing is clarifying the diagnosis. I'm saying this is what adults should know about it. I mean, they probably go through this when you get the first or second seizure, you get the investigation, so a lot of it happens and say you don't need to think about it. So history and examination, obviously, despite high technology, if you're in a resource-poor part of the world, you're going to make a diagnosis of epilepsy without MRI scans, EEGs, and it's going to be clinical history based on what happens to the person with the seizure. So you ask the person with the seizure, was there any warning, any lead up to it? What happened during it? If they lose awareness or consciousness, they're not going to be able to tell you, obviously. And then what happened afterwards? What did they feel afterwards? Were they confused, drowsy, lethargic? Were they weak on one side? Could they not speak? Had they a headache? Had they wet themselves, etc.? So then you ask the witness, of course, and we'll come to that in a minute, and the witness account is equally, if not more important. And then there's various blood tests. You could have a hypoglycemic attack and you may get a seizure-like episode. Your blood sugar is low from you took too much insulin if you're diabetic. So there is a medical workup, and obviously then EEG can be very important. Again, it is important. You don't necessarily need to do an MRI scan on everyone who's had a seizure. For example, if that group of seizures, primary generalized epilepsies, where the history is classical and you have an EEG, then there would be no indication for an MRI. And if you're struggling with a diagnosis, Dr. Lynch mentioned video clips, very helpful. We see those all the time in clinic. People bring in video clips of the episode. But video EEG, where you're connected up, if you're having difficulty with nailing the diagnosis, so to speak, then it's important to just think a bit further. Maybe more prolonged monitoring is necessary at times. And because there are epilepsy mimics, people who sometimes, I suppose the classical example is you're inside in a group of people and you feel a bit hot and sweaty and you say, God, and you feel you're going to pass out, and someone helpful beside you holds on to you, say, oh, don't worry, I'll hold on to you. And the next thing you kind of pass out and you might give a few jerks, and actually if you were laid down and put the feet up, that mightn't happen. So that is, when you take the details of the history, you realise that's not a seizure, that the main thing here is a faint with a few jerking episodes intermixed with it. So as I said, the basis for diagnosis of epilepsy is still clinical, despite, as I said, the explosion of high tech in the last 20, 30 years. And examination is important, obviously, and supplemented by investigations. The EEG is, we can do a routine EEG, a sleep-deprived one, video EEG, ambulatory, invasive EEG, subdural and epileptic. So there's all that. Most people don't need that, just a routine or possibly a sleep-deprived EEG. And then an MRI, as I say. EEG can often be normal. We have quite a number of, Dr. Lynch alluded to it already. You can have difficult to control epilepsy and normal EEG and normal MRI scan for that matter. So, and that can be frustrating, obviously, in the sense, like, again, coming back to Dr. Lynch's talk, if you tell a parent that their child has some rare genetic cause of epilepsy, it can be a relief to people to find out what it is. So if you have a normal MRI, a normal EEG, and you're still getting seizures, obviously that can be frustrating. Well, what is causing this? And obviously you may have to look at it a bit further if that's the case. But repeating EEG sometimes and sleep-deprived EEG, you can increase the yield of it. So the sixth area, again, this is the sixth point, the medical management of epilepsy. And again, you say, well, this is really one of the paradigm conditions where the patient self-manages the condition in conjunction with the multidisciplinary team, neurologist, GP, epilepsy nurses, etc. The mainstay of treatment, however, remains anti-epileptic drugs, with important recognition of the role of rescue medications like buccal midazolam or rectal diazepam is still used sometimes and effectively, and then the role possibly of surgery, vagus nerve stimulator. We're talking of neurostimulation now, and it's becoming treatment, but that hasn't arrived in this country yet. And then obviously very important, and attention to provokers of seizures, sleep deprivation, certain medications, drugs, lifestyle. So regularity. You heard Dr. Higgins talking last time about a routine, etc., to optimize your cognitive function. Was the same for seizure control. It kind of loves a routine. I mean, they say make boring people of us all, but it is really important, and I suppose you just have to ask someone. You can get. I see people coming in and they've had seizure freedom for a good many years, and they said, I was at a wedding last weekend, and I didn't go to bed until 5 a.m. I had to get up at 7 o'clock for breakfast, and I suppose you shouldn't get up for 7 o'clock for breakfast if you're maybe just after a long wedding. So then, and that's obviously can be very disruptive and disappointing. So I often feel it's difficult, especially difficult for people with epilepsy when you advise them about things like sleep deprivation and getting enough sleep, and say they're just started college, and it's really it would be countercultural to sort of stick to that lifestyle really in first year in college, at least from my memory of it. So yeah, I think it is very difficult, but still it's something that has to be addressed, and you can't ignore the reality. Rare, thankfully, but still a reality of sudden unexplained death in epilepsy. And Dr. Lynch has alluded to some of the associations with that. And obviously safety, climbing ladders, having a shower rather than a bath. Again, I've been asked about scuba diving and other activities. The medications, obviously, this is a list of all the possible medications going back to bromides from 1857, and phenobarbital, like I suppose a drug that's still used in 1912. So it's not much over a century, really. We've got drugs, good drugs for epilepsy. Some of these medications have fallen by the wayside for whatever reason. And the most recent drug is brivaracetam, which is Briviact, which has just come out last year. So there has been an explosion of drugs really since 1990s, which was the decade of the brain, and that's when a lot of drugs came on the market. But even since 2000, I'll count them 3 and 3, 6 and 3, 9 and 10 drugs since 2000. So that's still a lot of drugs coming on stream. And again, I'm sure everybody with epilepsy and their families know that no drug is perfect. The ideal is no seizures, no side effects. And it sounds simplistic, but it is that is the goal. That's the holy grail of treatment, really. And we continue to need newer and better drugs. That's just saying the same thing, really. No seizures, no side effects. And then when you're choosing anti-epileptic drugs, and again you say, well, a lot of people say, we'll let you decide, doctor, or we'll let the doctors decide. But I like to try and involve people in it, and obviously you have to individualize that treatment. You may have, you may be on other drugs, and depends on, obviously, the more obvious things about you, your age, gender, your medical and drug history, a history of drug allergies. And it may depend on your plans for pregnancy, or if you're pregnant, whether you're on the oral contraceptive pill, OCP as we call it, and there's the issue of folic acid with anticonvulsants in women with epilepsy. A lot of the time, you don't, like, the newer drugs are not necessarily better, in fact, and you often revert to not maybe phenobarbital, you do that sometimes, but you revert to some of the more long-standing drugs. I just mentioned medical cannabis. I suppose, again, Brian Lynch has talked about this, and there is the expert group advising the Minister at the moment about making medical cannabis available for epilepsy, multiple sclerosis, and also in chemotherapy patients. So I think we can say that there isn't a lot of evidence, and there's some conflicting evidence, but despite this, the use of cannabis is recommended in a controlled fashion for certain types of epilepsy. And again, we're maybe some of the childhood syndromes, in particular Dravet syndrome, Lennox-Gastaut, have been mentioned a lot. But I think any intractable epilepsy patient it might be considered. It's just, from my point of view, it's another option. So all those drugs I put up there, when medical cannabis may be another option for them. Colin Doherty summarised it well, I think, in saying that the medical cannabis will not work for everyone, will cause intolerable but probably not dangerous side effects in a few. But for those in whom it will work, it may be life-saving. That's really no different to if a person has failed 4 or 5 drugs, and suddenly you hit the jackpot, you're lucky with this drug, you may get seizure freedom or a significant improvement in control. Vagus nerve stimulator is another option as well. It's a bit like, even though it's surgery, it's not brain surgery, it's really, I consider it to be about the same as choosing another drug. The figures are approximately the same. You get about, for someone who's failed multiple drugs before, you get maybe 8 to 10% will get seizure freedom with the vagus nerve stimulator, and about 40 to 50% will get an improvement in seizure control. We need to, and again, I know for the newly diagnosed person, you're not rushing in talking about vagus nerve stimulator or resective surgery for epilepsy, but it's always something to keep in mind from the start, in the neurologist's mind and the GP's mind and in the person with epilepsy. Am I a surgical candidate for, say, a temporal lobectomy, which is the most common procedure? So I think we have to keep it in mind. There is a journey involved in epilepsy surgery, with neuropsychology, neuropsychiatry, video EEG monitoring, MRI scans, maybe PET scans, and you'll have multidisciplinary input into that. So epilepsy treatment is individualised, delivered by a multidisciplinary team. Again, the epilepsy nurses in particular have been a great advance in the epilepsy services over the last number of years. And we're very lucky in Sligo to have Geraldine O'Rourke and Cara Conway, and they do a fantastic job. Education, again, as I said at the beginning, it's very much a self-managed condition, or co-managed, I suppose, a bit like a lot of other conditions now, diabetes, for example. Consider for surgery, VNS, lifestyle issues, possible related disabilities, psychosocial issues, sudden unexplained death. Dietary, I'm not going to talk about that, but it was mentioned earlier, and complementary therapy. And again, in the interest of time, I know a lot of people will ask about that, but there isn't actually much known. We don't have much by way of evidence base about the value of complementary therapy for epilepsy. Again, know your medications, and again, if you're a 20-year-old on one medication, or if you're a 70-year-old on maybe 5 or 6 other medications, it's important to know for you as the person with epilepsy, and for your GP obviously, and your neurologist, to know the epilepsy drug, the drug-drug interactions, what's the effect on pregnancy, interactions with the oral contraceptive pill, and the role of drugs in menstrual epilepsy. I'm talking about interactions with warfarin, for example, statin drugs, cholesterol-lowering drugs, which are all widely prescribed. And the older drugs can be enzyme-inducing drugs, and they can interact. So it's important to know that. I'm just going to mention a little bit about valproate and pregnancy. Valproate is rightly so getting a bad press, and it gets worse, unfortunately, as the years go by. This is not to say that valproate, or Epilum, as you know it as, is not a very good drug. Can be an excellent drug for epilepsy, and this is where you divide the human race into male and female. Really, for a male, you don't have to worry about all the other issues you have to worry about for women. But certainly risk of neural tube or defects or spina bifida is well described. And it's really only in the last 10 years or so the risk of impaired cognitive development in children exposed to valproate in the womb. And then there's an association with autistic spectrum disorder as well. Apart from that, even if you keep pregnancy and a fetus and children out of it, it's not a popular drug for women because of weight gain. You can get facial hair, heavy menstrual period, polycystic ovaries. And obviously for males, weight gain is is probably the issue, and otherwise it's very well. In practice, we have to, sometimes we'll have the discussion with a woman where they have a certain epilepsy syndrome, you've tried all the other medications and your back is to the wall and you have to have the discussion, you may need to go on valproate. So, I mean, that's a discussion we have, but obviously it's an informed discussion. Social and other implications of diagnosis. Again, I go through this quickly. Driving, obviously, in my experience, one of the most difficult conversations to have with someone who's newly diagnosed with epilepsy. Employment, and again, Epilepsy Ireland do great work on that. Recreational activities, I mentioned swimming, surfing, scuba diving, all that. I suppose the uncertainty and unpredictability of epilepsy is what's the most difficult thing about it. When is my next seizure? Where will it happen? What will I be doing? Will I wet myself, hurt myself? And of course, can I die from a seizure, or will I die? This is an old study, but still a good one, indicating the concerns of people living with epilepsy. And again, they all relate to managing your life, going to get from A to B without worrying about it. And driving, obviously, is the big one there. And again, Andrea Higgins mentioned mood, stress, memory, I suppose, could come into that as well, and safety. So they're all issues. And independence, obviously, if you can't drive, you're depending on someone else maybe to take you to work, and it can be a really very difficult issue. And I think Epilepsy Ireland, I'm showing my that was a slip there. Epilepsy Ireland. Okay, I'm nearly through. Sorry. Epilepsy Ireland, I would support their campaign for trying to get people support in that issue about driving. So there can be, this has been looked at, the psychosocial consequence of epilepsy. These are not inevitable at all, by all means, and that's why I want to emphasize the positive. But there is, studies have shown a higher rate of unemployment, financial hardship, social isolation, stigmatization, and people still don't want anyone to know they have epilepsy, and it's still understandable why that is the case, anxiety, depression, and the loss of control that goes with it. And again, we're in Sligo. I feel lucky as a neurologist coming to Sligo because they've got two great things going for it for the two major neurological conditions: epilepsy, with Training for Success in Sligo IT, and the MS Centre, which is unique in the country. So, and again, there's a stand here so you can find out more about Training for Success. Number 9. Research, okay. I'm delinquent on that personally, but there's a lot of very good work being done. David Hinshaw's name was mentioned, the Royal or CSI group, Future Neuro. Pharmacogenomics, again, Norman Delanty has done a lot of work on that, the genetics of epilepsy and the pharmacogenomics, the epidemiology of epilepsy, and service delivery. And this is where a lot of, cold-face work is done about how many patients see what sort of services. And number 10. Or should this be number 1? Anyway, as I say, from number 1 to 10, they're all on the same plane. Okay, so, and again, I'd like to wish Epilepsy Ireland a happy 50th birthday. And they do, obviously, you can see from Peter's introduction, they do fantastic work. It's a great organisation, and they're very supportive to me, and obviously, they've got great people working for them throughout the country. So I think we're lucky to have Epilepsy Ireland. And obviously, there's Facebook and Twitter, etc. as well. I didn't put that in there. So they're my top 10. Okay, is it Justin Bieber or is it the Beatles? I don't know. I suppose depend what age you are, etc. So I want to thank you for your attention.